So, good afternoon, everyone, and welcome to today's Expert Speak session titled The Role of Diagnostics in Early Disease Detection, How Early Diagnostics Can Improve Patient Outcomes and Safety. My name is Jaya, and I'm an additional director at NATHEALTH. It's a privilege to host this session on a topic that is so vital to the future of healthcare. So, we have an esteemed panel of experts joining us today who bring a wealth of knowledge and experience in the field of diagnostics and early disease detection. Let me introduce our distinguished panelists. So please welcome Dr. Sameer Gupta. He's a senior cardiologist specializing in complex interventional cardiovascular, structural heart, and peripheral procedures. He's a director at Group Cath Lab, Metro Group of Hospitals in Delhi, NCR. And welcome Dr. Rajesh V. Bendre. Dr. Rajesh Bendre is the Chief Pathologist and National Technical Head at Apollo Diagnostics Private Limited, who, with over 23 years of experience in clinical chemistry, uh, brings his expertise in hematopathology and molecular pathology. And we have Dr. Salil Vanyawala. He's the Director and Consultant Geneticist at SN Genelab Private Limited. He holds a PhD in genetics and specializes in prenatal genetics and molecular oncology. We have Dr. Vijay P. Nandu. Dr. Nandu is an honorary consultant physician with over 40 years of practice. He has a special interest in infectious disease, diabetes, cardiovascular disorders, respiratory disease, multi-system disorders, and connective tissue diseases. We have Vijay Kumar, who is the head of portfolio solutions at Ross Diagnostics India, overseeing enterprise and hospital key accounts and international business across India and neighboring markets. And we are so delighted to have Dr. Nilesh Shah as our moderator today. Dr. Nilesh Shah is the president of Internal Assurance and advisor to the CEO at Metropolis Healthcare Limited. With 38 years of experience at Metropolis, Dr. Shah has significantly contributed to the organization's growth and the establishment of high quality standards across operations and services. So now I would like to hand over to the session to Dr. Shah, who will outline the objectives of the session and guide us through the significance of early diagnosis, the challenges and the role of technology in overcoming them. Thank you, and over to you, Dr. Shah.
Thank you, Jess. Thank you very, very much. I think it's a subject which is very, very dear to me after spending almost 4 decades in lab industry and seeing all good, bad, ugly side of it and seeing journey across. And this is subject which I would always love to speak anytime. Today we are going to talk lots on diagnosis, lots on diagnostics, but with lab focus. And our larger focus is going to be early diagnosis. Now, it's a time where people are talking about evidence-based medicine compared to past. When patient, when he walks into a doctor, he wants to get treated fast. He doesn't want to go through investigation and all. But today, specifically post-COVID, people are very, very sensitive about getting diagnosed, and that also early diagnosed before a disease becomes a burden, unmanageable, or before any treatment is given. So in the era of evidence-based medicine, a reliable diagnosis and early diagnosis, both are very, very important for a good patient safety. And that is what today we are going to talk about. I'm so fortunate that I've got a very balanced panelists available with me. I have somebody who is a manufacturer, who is an innovator from a company called Roche, Mr. Vijay Kumar, whose new innovative products actually help laboratories like us to deliver the requirements put by clinicians and patients in timely manner and with good quality. I have two laboratorians with me, Dr. Rajesh Bendre, who has got a very rich experience, is a pathologist with very versatile knowledge and who has handled multiple portfolios in various companies. And he's somebody all-rounder I've ever met. And then I have a geneticist like Dr. Salil Vanyawala. Genomics is one subject in big, deeper sense we are going to talk about. And people say future is genetics. So this panel is not complete without Dr. Salil kind of a person joining. And you talk of medicine and do clinicians won't be there. That doesn't happen. And that's not right. And we have very good two clinicians here. We have Dr. Sameer Gupta, cardiologist, And we have Dr. Vijay Nandu, who is a physician and very focused on infectious diseases. So I want to talk about various subject. I have some questions in my mind, and I'm going to open it for forum to answer about it. And at the end, we will have some case studies. We will also do some concluding remarks and so on. So let's make this session very, very interesting. And we are going to make a focus effort on this session that it not only helps healthcare industry people who are on scientific side, but also somebody who's non-technical, he can understand easily. Okay, what is an important of lab? What is the role of lab in patient management and patient safety? So let me start first question with Dr. Rajesh Pendre here. Dr. Rajesh, you are a very large laboratory and nationally known, probably internationally known laboratory, and you keep coming up with new tools. Can you identify few tools for early diagnosis you recently came up in last few years' time, which is helping patients and doctors to make decisions faster?
Yeah, thank you, Dr. Nilesh, and thank you, NATHEALTH, for having this organized today and being privileged to be a part of this panel member list. So, addressing the first question here. So, when we talk about lab diagnostic tests, every lab has a responsibility in selecting and choosing the tools or the tests that they are offering to the patients. And when I say this, the main document that every lab would try and refer to is the manufacturer's kit insert. And that manufacturer's kit insert gives us a lot of information. And there are two important things in that kit insert which, as a laboratorian, we categorically look at for a diagnostic test. And one is what we talk about as sensitivity, and another is the specificity. So these two are important aspects of a lab test. And as a lab, we need to very categorically look at it. Sensitivity to tell or explain in a very simplistic term or in language would be that this test, what it tells would be the least amounts of false positives. So we don't want this test which I'm using or offering to patients and giving out some false positive information. So that is looked upon from a statistic point of view as sensitivity of a test. Similarly, I want this test to give me the best and the maximum of true positives. And that is what is given by what we call it statistically as specificity. So these two are published in the kit insert document by the manufacturer. And as a good lab practice, every lab, and it is also a guideline or a NABL or any other national regulatory requirement, that we need to do an in-house test verification or test validation, which we will verify the claim of the manufacturer as to what they have said in terms of sensitivity and specificity to be specifically speaking about. There are many other parameters we look at, but these two are very critical when it comes to diagnosis of a patient, and especially as per our today's topic, which is the early diagnosis of a patient. So, having said that, to narrate some of these simple examples, I would like to take a few examples in three segments. One segment is the infectious disease, another segment is oncology, and third segment is in cardiology. So when I talk about an infectious disease, let's talk about simple diseases. When I talk about we are the monsoon season which is on right now, and the diseases which there is always an upsurge of certain disease, infectious disease, is mainly malaria and dengue. So the early diagnosis when we talk about in malaria and dengue, the way it has advanced in the last decade is what we talk about the antigen tests. So today the malaria antigen test, which is simple rapid test, has got such a good sensitivity and specificity that it almost matches a malaria PCR. So versus similarly when I talk about dengue and how it has helped, a simple dengue NS1 or dengue antigen test has helped picking up dengue much earlier. That is just the early 2 to 3 days from the time of fever versus serology, which takes 5 to 7 days for serology to pick up. So these are simple examples which have helped us. These are simple rapid tests, but a very good sensitivity and specificity to pick up early diagnosis of these basic infectious disease. And most of the labs have adopted to these kind of testing offered to the patient. When it comes to oncology, Here, the world is slowly or gradually adopting from the field of serum tumor markers being used for so long to liquid biopsy or NGS based or molecular based technologies. But I suppose there is more work to be done on this, and maybe in today's discussion, more of these things we will highlight. And when it comes to cardiology, from basic CPK, CPK-MB, we have moved to newer generation tests like troponin I, troponin T, and HSCR, which has helped differentiate patients and identify acute myocardial infarction in a much early stage, where time is a essence in treating patients. So I would say these points to that question.
Thank you. Very, very useful. And I'm going to connect this to both the clinicians. We lab continues to innovate, add new tools, make tests more sensitive, but how much it is helping clinician? I'm sure clinicians will have real-time example. And I'm going to ask Nandu sir, if you would like to share some example where an early diagnosis, whether infectious disease or anything else, which helped the patient manage his disease disorder in time, and you could create a safety for patient. Would you like to share some examples, sir?
So, Dr. Bendra, I was rightly agree that NS1 and malarial antigen are very common tests, and the actually the crux, the seasonal fever right now, which we see right now. All of us are the same epidemic in the same area right now, managing those issues on a day-to-day basis. So the first test, people, when the person comes with fever and you have a low platelet count and other things, and with body ache or other things, you would ask for those. But if they are negative and there's still a little low platelet, or there is a borderline, you're not very sure, and you think there's still a seasonal fever, the tropical fever profile, which is a multiplex PCR based, is a very useful test now and helps us to pick up a lot of things. And it has genuinely helped us to pick up once in a while early cases of rickettsial disease, early cases of leptospirosis. Because what happens is leptospirosis, we used to have only leptospirosis IgM, and which would take time before you really pick it up. And you're maybe only suspect that it could be leptospirosis, but you're never 100% sure about that particular issue. And I remember patient who had come in a situation with directly into the ICU with multiple issues and jaundice and other features. And you sent a test, you got a positive report, leptospirosis, and you were clear that you are managing only one particular aspect. You don't have to go through the whole gamut of multiple antibiotics and treating as a spectrum of multiple drugs or something of that sort. So that's one. The same way, we usually believe that rickettsial diseases are not very common, or they are common in particular areas, not common in the city of Bombay or a local person which is in Bombay or something of that sort. But I have had probably about 4-5 patients that people were missed or they're diagnosed late. Out of them, 4 out of 5 actually died.
Oh.
And 4 out of 5 died because they already had changes of gangrenous changes at the tips of the toes or the earlobes or whatever other place. But I have had patients where I suspected rickettsia. We did a PCR specifically for that and we picked it positive. And there are patients where actually are not suspected rickettsia and we did a multiplex PCR. We got it positive. Early therapy cured the patient completely. So I think it's a very important aspect. We believe that few things are not very common in particular cases. We know rickettsia is very common in South, where it's CMC Velo will see huge number of cases of rickettsia. But even in Bombay city, you can see multiple patients of life. So I've seen somebody in Kutch. That patient was in Kutch, went to Ahmedabad. He went to Bhuj from there. He went from there. He went to Ahmedabad. There he was managing the ICU, multiple drugs, including doxycycline. He came back to Kutch because they thought that we can't do anything much. We can't afford. They came back to Kutch over there. I was seeing that particular patient. This is about 2 years back, 2.5 years back, and we got a serum ammonia high. I thought maybe it is hepatic, and we stopped his doxycycline. I then started getting some changes of gangrenous changes on the skin, and I put it back on doxy, sent a IgM at that time, and then we got rickettsia positive. So these are things which, if we was multiplex PCR was done at that particular time, they would have probably picked up, and they wouldn't have actually had multiple problems like that. So I think it's a very important test. So this is one of the examples where actually it makes a big difference. There are multiple similar scenarios which one can look at.
Excellent. So what I learned from you that traditional antibody tests getting evolved to antigen for better sensitivity, but we are talking about now PCR, which not only is more sensitive, but also gives you answers for multiple infections together, and that helps. And you also have a cases where in absence of such tool, uh, patients died. So that is heartening to know. Let me ask same question, Dr. Samir. Would you like to share your experience of anywhere there is a early diagnosis helped or misdiagnosis actually ruined the situation? Would you like to share something?
Yeah, thank you so much, Dr. Shah, and I think thank you so much for organizing this panel and inviting me. I think this is a very important and a valid discussion that we are having, and it's good to have all different stakeholders.
Hmm.
First and foremost, in 2024, when we as clinicians, I as a cardiologist, Dr. Nandu over here as a physician, when we are making a diagnosis or when we are treating a patient, we are definitely utilizing some sort of lab diagnostics to make a decision and to try and confirm or refute what our clinical judgment is. So it is so these lab and the diagnostics, they play a very important role in our treatment of this patient. As a cardiologist, most of my practice is to deal with heart disease and vasculature problems, etc. And that is where troponin comes in, right? Troponin is a biomarker. It's a biomarker which is released from the muscles of the heart when somebody's having a heart attack. What I've come to realize is that, working in a tertiary care center, we are getting patients from all over UP, Delhi, NCR. That's where I practice. I practice in Noida, which is just a suburb of Delhi. So, we get patients from all over Western UP, Eastern UP, and over there, when somebody has chest discomfort, they usually end up going to a local doctor over there. They may or may not have an ECG. If they do an ECG, if the ECG does not have very significant changes, but they are concerned, the first thing they do is they do this card test of troponin, right? They put the troponin, they put some blood over there, they get a troponin test. And oftentimes these tests, the quality of these tests may vary. And we'll have this discussion about the quality later, but these tests may not be done properly or they may be expired. And these tests, in spite of a very high clinical suspicion, come back as negative. So then this patient, basically heart attack gets missed because that local treating physician in a tier 2, tier 3 town, or sometimes even a tier 4 town now says this person does not have heart disease because this test of his is negative. And then he gets kind of lost. He gets, treated for different things before he goes to another physician and they do a repeat blood work or further advanced investigations. And they're like, no, this guy's having a heart attack. This guy needs to be transferred out. So that is one very common clinical situation that we face with. But also practicing in NCR and, you are often also exposed to sometimes at a personal level and a family level as well. We're talking about the rainy season and infectious diseases. So I'm often sent reports of family members, friends from my network of people who have a fever. And, the usual trajectory of anybody with a fever is, when somebody has a fever, they normally take a paracetamol or a antipyretic drug themselves. It doesn't get better because they're like viral hoga or something along those lines. They call the local pharmacist up. They start an antibiotic, right? And then when the fever, and then after they've taken a dose of the antibiotic or they're about to start the antibiotic, they typically call you up and say, doc, what should I do? Should I take this antibiotic or not? And then, you usually tell them to get a fever panel test done. And that is where some of the challenges in diagnosis come, I feel. This is something that I've learned not only in medical college, obviously as a cardiologist, but also more so in my practice as well, where, for example, in typhoid, right? The blood culture is the gold standard. You all know that. But usually the blood culture should be done before the antibiotics are given. Then the other tests that are available is the Vidal test. The Vidal test is a very non-specific test. You get a lot of false positives and false negatives, and now you're kind of stuck with what information to do with it. You can do a rapid antigen test, but in an endemic area like, in half of India, this Vidal test is very highly false positive. And you think it may not be typhoid, it's kind of not making sense, but it's a part of the fever panel, and now you're kind of stuck with this information. So, that the diagnosis can either be missed in this scenario because the test is not sensitive enough, or it may be overdiagnosis because it may be it's not that the specificity can be challenged. Similar case challenges you even face, like Dr. Nandu mentioned, sometimes with dengue and sometimes with some of the other illnesses like malaria, right? For example, that malaria, the specimen has to be done at that particular time when the person is having fever. And nowadays, with most of the home collections available, the person who's coming to check the blood at home may not come at a time when you're actually having a paralytic episode. So
Yeah,
I think these are all the different challenges that we as
true.
clinicians and as lab people face in treating patients, and we try and do the best we can.
This was very, very good answer, and I think I quite loved your falsely negative troponins and how it affects you. And that is where Dr. Rajesh's point comes in picture. Okay, before you adopt any test, sensitive and specificity, checking, validating whether it is actually working or not is very important. It's a responsibility of a lab before they actually adopt a test. All these checks have to be done. Uh, After talking about this early diagnosis, let me also talk to indicate that, generally what people perceive that a lab is mainly for diagnosis, but lab has gone much more beyond diagnosis. Today, you have tests for predicting a disease, you have a test for early detection, you have a test for screening, you have a test for confirmation, you have test for prognosis, checking the prognosis, you have a test for diagnostic. It helps you with treatment identification and so on. So when we talk about early diagnosis, I want to go a little behind and talk about predictive medicine in laboratory medicine space. Now, a lot of tests we have for prediction. And this is the right question for Dr. Salil to come in, where genomics actually has opened up a big Pandora's box for us, where list of disease and disorders, you can predict it before they actually onset occurs. Salil bhai, please tell us, give it some example, what kind of predictive diseases can be now successfully predicted. There have been some concerns about how this test gets validated. Prediction means, oh, kabhi bhi hoga, we don't know when it will happen, whether we should rely or not. And when this predictive disease, if you get some disorder, you will stay in stress, you will add to a stress rather than it helping you. Such issues occur. So you please support with some example that you advise a patient a predictive test, they did it, and how their life improved and how they could prevent a disease or disorder. If you can just give us some gyan about it, you can take your time on that. Yeah, thank you.
So, thank you, Dr. Nilesh, and the panelist. Genomics is a broad spectrum. Now it has changed the entire medical fraternity or the entire medical field. If we talk about starting from tuberculosis, now you have XDR. You pick up only one test and you pick up the entire mutations which are there, which are responsible for drug resistance. This is the basic of bacteriology. COVID is one of the biggest examples. Sequencing, we did a lot of them. Again, we pick up those particular mutations which are there, and from that we predict that what would be the outcome and what would be the quality of life of the patient. This is a very small area. If we go above that, the best thing we see is the newborn screening. You have multiple diseases which we can treat them, like MSUD, like other diseases which require, for example, that you treat that patient with particular type of a therapy, and the patient can survive for years together without any. If, for example, thyroidism, if you don't treat that patient initially, then there is an issue throughout the life. So what important is early diagnosis. How early you pick up those those tests, the diagnosis is very important. For example, if we take this, the other example is spinal muscular atrophy, yeah, DMD, muscular dystrophies. So these, if we pick up, we can stop that particular disease. You have therapies, gene therapy, though no doubt they are very expensive at this moment, like for spinal muscular atrophy. You can treat that patient easily. The patient can survive for the lifetime. So there are multiple areas you have the early diagnostics available with us, early treatment available at the time. If it is being treated properly, with proper drugs or a proper metabolites, it creates wonders for the quality of life of that particular patients. So this is not only the thing. If you consider adult kind of a genomic disorders like hypercholesterolemia, hyperlipidemia, you have treatments for that available. There is a cardiologist. We have a lot of long QT and arrhythmia patients. You can screen that patient. We recently had a family whose father died of arrhythmia 40 years back. After 40 years, we have two sisters. One of them at the age of 60 years had developed arrhythmia. She is treated in a Holy Hospital in Mumbai. And she had got that done. And after that, another sister got the same request and we did it. And she had the same mutation. So pacemaker had been kept for both of them and they are doing quite well. Now we did the testing of their children. Two of them have already got this mutation positive. So this is how we can predict, and they are still married. So we have the chance to avoid doing a prenatal testing in the next pregnancy. So this is how we can avoid this cardiac anomalies, fetuses also. This is a basic example of doing it. We have a lot of thalassemia patients, sickle cell anemia. We can do prenatal testing if it has been done early diagnosis. So that is the area we can save the couple from a lot of problems which they are going to face throughout the lifetime. Because if you see thalassemia major patient, they survive for 20-25 years with a lot of problems. You have to give multiple doses of a blood transfusion, and the quality of life after a certain year is very bad. So that is how, but because of genomics, we have done many patients. For example, recently we have 3 patients whose first child is thal major. We tested them. There were no HLA matched siblings for them. So what we did is we did pre-implantation genetic diagnosis of this patient. The embryos which were normal or having a carrier were tested for HLA typing with the first child. So we had this embryos which were transferred, which were normal and HLA matched with the first child. They implanted it. They had a normal child. They delivered. They had stored the cord blood, and they have eventually already used 2 of them for the transplant of that affected thal major child. So look at the importance you have of this particular genomic treatment or the genomic diagnostic. And most of the time it is previously 20 years back where we started, there were a lot of problems because of the availability of the instrumentation. But right now that is a tremendous revolution. We cannot imagine what we can do if you are having a good genomic lab. Everything is possible. If you consider this, we have multiple patients of oncology also. We have, initially we are doing in 2003 BCR-ABL that had the targeted therapy, only one of them was there for CML. Now we have second generation, third generation therapies, which can easily clear, means if the patient is of having a CML, they survive for 15-20 years without any problem with a single drug. We have seen so many patients with us in follow-up for many years. So this is the revolution which has created because of molecular diagnostics. No doubt there are limitations, maybe 0.5 to 1% of them may give a false positive, negative report, but they are worth it doing. If you go on the other side, like oncology, now oncology is a totally different area. I don't think so any oncologist treat their patient without doing a basic oncology gene or molecular testing. If you have CA colon, they will go with MSI. If you have CA lung, you have an entire battery of tests. Again, there are targeted therapies available. You have now availability of CAR T cell therapy if the patient is of ALL. So multiple option is there, but basic requirement you need to do is the genomic part and molecular diagnostics. If you are talking about early detection, initially that was thought that BRCA was the only responsible mutation or the gene which causes breast and ovarian cancer. Everything is changed. We don't do only BRCA. There are multiple hereditary cancer panels, and we know there are so many different genes which are responsible for hereditary breast and ovarian cancer. So everything is changing. Again, we think that only BRCA causes breast and ovarian cancer. No, it causes prostate, it causes pancreas. We have seen it in our regular practice. So it is not that only one or two genes. The number of patients we do, the number of advanced tests we do, the number of more and more mutations or genes we do, will be able to identify that this particular mutation is not only restricted to that particular cancer. Initially, we are treating those patient with HER2 for Herceptin for CA breast. Now we have CA stomach, esophagus, where HER2 is positive, you treat that patient. Same thing is with PARP inhibitors are there, where the HRR pathway genes are positive. You have PARP inhibitors available, which creates a wonder for this particular mutation. So the mutations are equally important. If we pick up these mutations or the genes very early, the quality of the patient life is very good because you have a targeted therapy. You can avoid in first phase these chemotherapies which are creating a lot of issues for that particular patient. So this is a very broad spectrum of test treatments as well as multiple areas where you can use this genomic testing. Oncology, say from basic infectious to oncology, everything is being covered.
Excellent, Salil. I think whoever is going to listen to this video and specifically what you said is going to be very delighted that genomics is taking such a path and such a shape and such a horizon that it is going to change life for patient and it is going to help clinicians in big way. Very, very delighted to have your answer. And I'm going to now move to Vijay from Roche, the company who has been a big innovator across the globe. Labs like us are largely dependent on this company's research, coming with new biomarkers, new testing tool, more sensitive, more specific technology advancement, and so on. So Vijay, please tell us what has been last 3 years, the list which you brought it for labs for the benefit of clinicians, which does early diagnosis, and what we should look forward to in future, which we'll talk later. But right now, you can tell us what has come in last 3 years, and any success and failure story around that if you want to narrate. Vijay, are you on call? I can't see.
Yes,
Yeah,
and thank you, Dr. Nilesh. I think this is a great pick as a topic, very, very relevant to the times that we are today. I think Dr. Rajesh spoke about sensitivity. You spoke about, specificity, sensitivity. Dr. Samir spoke about false negative troponins, misdiagnosis in critical cardiac situations, and then Dr. Salil spoke about next generation diagnostics. So I think it's really covering the spectrum. Since the time, Dr. Nilesh, I joined Roche, which was about 6.5 years back, there is one thing which I have definitely learned, and that is to appreciate our body as a system. It's a fantastic system which keeps expressing molecules of certain types whenever it undergoes any changes or distress. Now, I think it's up to us, it's up to our technology to pick up those changes. And if we are able to pick up those changes, then that is our topic for today, that our body does express these kind of molecules many years before the onset of practical symptoms. And the whole idea is this behind Roche's R&D efforts, where the company spends almost 1.3 lakh crores in rupees every year on R&D, and just to get this going. There is something called limit of detection that you will see in all method sheets, assay method sheets coming from Roche. Now, I just want to dwell upon it a little bit because this is fundamental behind the sensitivity that we talk about. It means actually limit of detection means the copies of molecule that the test is capable of picking up. And with the lowering of limit of detection, the assay obviously becomes sensitive. And the advancement in technology, right? It started from micrograms in late 1990s. We used to measure micrograms every milliliter in 1990s, and then it gradually moved to nanograms. And you know what nanogram is? It's a 1 billionth of a gram. And just to put this in perspective, our lightest hydrogen gas, if you pick hydrogen gas in 1/10 of a millimeter side of a cube, which is this big, I think less than a hair, that is 1 nanogram. And then we are talking about 1 picogram. Now, 1 picogram is basically about 100 copies of bacteria in a blood. Now we have to pick those. And just to talk about this technology, if we get an assay into picograms as the limit of detection, then the application of the assay that you have been seeing on a normal basis, that expands substantially, because then it moves to asymptomatic individuals, it moves to normal population, where if you are able to pick that sensitivity, then you can prognose, you can diagnose, you can screen those people for serious diseases, and then you can have those lifestyle changes also coming up. So I would just quickly, like to display actually one slide which will help appreciate this point. I hope this is visible.
Yes.
Yeah.
Okay. NT-proBNP, and I think all these assays, these are launched in the last 3 years with added claims as the limit of detection got down. NT-proBNP, very familiar. I think earlier we were using sometimes proBNP, but now the market has completely conclusively moved to NT-proBNP. HS troponin T, another one where asymptomatic individuals can be screened early. Alzheimer disease, absolutely the brand new test for neurology. And this is a CSF based test, but our company is investing a lot in research and development to bring out a plasma based test. So how fantastic it would be to have this deadly disease. I know, this is, I have spoken to the caregivers of these people, and I can tell you, this could be a game changer. And then we have now AMH for PCOS. All these, except probably Alzheimer's, are the assays that are familiar, but the applications have expanded because the limit of detection, because of the technology advancement, has gone into picograms. And I think that's what I would like to share. And thanks again, Dr. Nilesh. I think because of the Metropolis lab priorities, we are really validating these technologies on a regular basis in your labs. So thanks for that as well.
Pleasure. So I think these are very four innovative and very, very good tests which are coming up for the diagnosis, really going to help patients and doctors both. I want to move to now next subject after expressing all of us unanimously that early diagnosis, prediction, both are very, very important and is helping patient safety in much bigger way. Let's talk about taking a wish list from both our clinicians. Um, let me start with Dr. Vijayanandu. And I want to ask you, sir, okay, is there any opportunity for labs where some disease disorder, we are missing it because early diagnostic tools are not available? Would you like to give a wish list to us and Rosh, who is here, and you want to give some examples on that? Over to you, sir.
Right. So I think the first thing is, let me talk about few tests which are available but not uniformly available. And so they are available maybe only at selective places, maybe one or two places only in the city, whole town, and not available at major places. One. Second thing is that availability is only not very frequently, it's infrequently. So basically it doesn't help you in the same particular manner. So these are first thing I will talk about. And then probably we'll talk about few things where we probably have better facilities to look up those particular issues. So let's say if you're looking at, I'm looking at from the ID point of view right now. I'm looking at, say, let's say we have a person who's got an immunosuppressed patient, and you're looking at a fungal disorder. and you're looking at a urine histoplasma antigen. Urine histoplasma antigen, though it is available at few selected places, not available at multiple major laboratories also. And very difficult to really ask for, or it is not available on a day-to-day basis. Secondly, even beta-D-glucan. Beta-D-glucan would be the first thing to look at whether he's got a particular fungal disorder or not, especially from the Candida point of view or from the Aspergillus point of view. But it may be available at only hardly 1 or 2 places in the city of Mumbai. And maybe again, they might be doing it maybe twice a week or thrice a week and not necessarily on an everyday basis. So what happens is your culture might come positive before why your beta-D-glucan may come positive if you're not really looking at it that particular manner. So that's the one place where it probably makes a difference, where availability of a test, though it should be done, it is not available even at major laboratories. So we don't look up at that particular issue. The same way I was talking about Zika, like we have a tropical fever profile, which we are doing now. Now, few laboratories include Zika on a regular basis, few laboratories don't include. Zika virus infection is again, may not be very common in this particular country, but there is no reason why it cannot become a very big infection, because it is spread by Aedes aegypti mosquito, which is very common in this particular country. We recently had newspaper report where 2 patients of Zika were picked up from Pune. Now, if we have a tropical fever profile, you could probably pick up, and everybody is doing, including Zika, then you could probably pick it up. But I may send it to a tropical fever profile. There will be laboratories which don't include Zika, and you don't find out because the clinical picture is very identical. Maybe just rash, fever, joint pains, myalgias, and conjunctivitis. So, how am I going to suspect this little right sclera and skin rash? Multiple other things will give the same picture. But you have a Zika on the panel, you would probably pick it up early. So I think these are things which are probably important to look up at that particular issue. Look up from the point of view of country. The patients, if I look at a situation where a person comes from Bihar, I have patients who are from Bihar, and the only diagnostic test is either early testing is basically from a serological testing is an antibody, RK39, but it's antibody-based test, and you don't usually pick it up every time positive. Then you have a possibility of looking up clinically that he's coming from that particular area. He's got from pancytopenia with low platelets, hepatosplenomegaly. You think of it, but the diagnosis confirmation will come from a bone marrow biopsy or splenic pulp biopsy. Splenic pulp biopsy is not very commonly done in the city of Bombay, but probably given up multiple places. Bone marrow biopsy. I had this patient about maybe 15 years back where bone marrow biopsy was done twice. RK39 antibodies was done 3 times, negative. Bone marrow biopsy done twice, negative. Nobody picked up LD bodies. Finally, we gave an empirical therapy and he responded. He had fever for almost 3.5 months, 4 months, no response. Now, if a facility like a PCR is available for such sort of patients, I think it may be very useful, maybe from a tissue, whatever. But an helpful diagnosis, picking up early and treating it properly. Just a single dose, high dose of liposomal amphotericin B would cure the patient. So I think that's a very important aspect where you can look up that particular issue. The same thing is we're looking at Candida infections are becoming very common, and CLABSI, catheter line associated infections. And here, Candida is a very common infection. We could do a BDG early, a beta-D-glucan, and say, okay, that's a possibility of a fungal infection. Put him on right therapy, especially if the patient has multiple scenarios where there's a likelihood of his becoming a likelihood of his fungal infection, especially Candida. You will put him on empirical therapies with fluconazole or whichever the drug. The issue is if we have a lab-based test, which not only tells you that there is Candida, but can differentiate a type of Candida. So you can probably, in fact, consider that this patient is going to respond only to caspofungin or becafungin or whatever, or he can respond even to fluconazole. So if we have that sort of a testing available, it would become easy for people, clinicians to treat such a patient. Otherwise, he goes to a hard drug, which becomes costly, and sometimes may or may not be possible for everybody to manage because of the cost issues. So otherwise, every patient who's got that and you feel he's got septic shock and you're treating it with antifungal, you go straight for fungins, caspofungin or becafungin or whatever. Looking at that at an early phase becomes important. Among the Candida auris has become a huge course for this. And if again you have a method to look at which drugs are going to work early, I think it will become a very, very important aspect. TB, we have drugs available the same way. Fortunately, a lot of things have improved. But even there are some fallacies which I'll talk when we come to probably further questions or something. I think these are probably common scenarios where in infectious diseases, we should be probably be looking up what we can do better for our patients.
What I saw was largely on mycology front. There is a gap about, and second thing, panel standardization. These are the two large message which I got from you. And PU space, PUO space. I think these are the three places where the way abundantly tests are available uniformly across, they are not available. And there is a gap in panel. There are some technological gaps somewhere. I think that's a good for all laboratorians on the panel to hear and people who are listening. That is a great message. I'm going to ask Dr. Samir same way.
I want to mention one more thing. Nowadays, we are seeing more and more elder population. We are seeing patients who have been on multiple antibiotics, prolonged hospitalizations, multiple ICU stays, multiple places, repeated patients at multiple places, immunosuppressed because of therapy of cancer itself or chemotherapy itself. HIV may be controlled. This may not be a major factor now. But these are all different factors which are responsible. And hence, we are going to see more and more of such infections. And that is why it's very important for us to look up this particular issue. The same thing may also occur for viral infections. But I think we can look up those issues.
Sure. Look, Samir, where do you see challenges where you have to manage a patient in absence of early diagnostic tool available? And what is a wish list you want to share with the labs? Okay, this is what something I would look forward to for better patient management.
Yeah, absolutely. Thank you. I think this is a great forum for a clinician to share his wish list because we've got all the lab people over here. Now, when you think of cardiology, right, when you think of cardiovascular diseases per se, there are about 4 emergencies you have, 4 big emergencies, and these are life-threatening emergencies, right? It's a do or die situation. One is a heart attack, right? One is a myocardial infarction heart attack. The way to diagnose it is with an ECG and a troponin blood test. Over a period of last 20 years, 30 years, the availability of troponin has certainly has increased dramatically. And now most tier 2, tier 3 cities do have the troponin in the rapid test format. I used to do it during my internship back in Sutherland as well. But now similarly, it has become more ubiquitous. We can keep debating about the quality and the sensitivity and specificity, but people are aware of it. The 3 other medical emergencies is a stroke. Okay. Now, for the sake of the common man, a stroke is when there is a blood clot which happens in the brain, and because of which the person may lose a part of functioning of the body, right? So you can lose some functioning of the hand, some functioning of the leg, or complete paralysis depending upon the area. You can have difficulty speaking or inability to speak, which is facial deviation. And right now, for the most part, this is the clinical diagnosis. Right? This is the clinical diagnosis. After the patient comes to the hospital, sometimes, these patients, normally this event is to happen at home. The immediate response of non-medicals is, shake them up a little bit, try and, make them have some water, check their blood pressure. They lose a good amount of time in this. Then they come to the hospital, and then in the hospital, they may get a CT scan or an MRI to try and diagnose what's happening. And that delays treatment, right? That delays treatment. The question is, and the reason is because there is a lack of blood flow to a part of the brain. Depending upon which part of the brain it is, you have the symptoms. The question is, are there any enzymes or any markers which are possibly released, which we may know, which may be in research purposes, that can kind of give you a clue, like it is in a heart attack, that yes, this person, that symptom that he had was possibly because of a lack of blood flow to the brain causing a stroke, right? So that is one big thing, right? The second thing is a pulmonary embolism, right? A pulmonary embolism is a condition where there is, I'm just trying to simplify these things for the sake of the common man who may be listening to this. But a pulmonary embolism is a condition where there is a blood clot which is formed. It goes to the lungs, and the person can get short of breath. Most often, when somebody goes to the emergency room with shortness of breath, if the blood pressure is stable, then they are treated for asthma, lung condition, they may get an X-ray, then at some point they get a CT scan or an echo, which kind of cues them into having a blood clot, right? And we often get patients who, from the peripheries, where they've had a pulmonary embolism, it's been undiagnosed, now it's 2 weeks, 3 weeks, 10 days, 15 days, sometimes months. Um, so is there some marker which is coming from the lung that can be diagnosed to give you a clue that this is a pulmonary embolism? Because pulmonary embolism is fatal, right? Many times it can be fatal, depending upon the size of the blood clot. So we use surrogate markers to try and give us a clue if somebody's having a pulmonary embolism. The third condition I want to talk about, the fourth condition actually, is an aortic dissection. Okay, is an aortic dissection. So the aorta is the main vessel in the body, and sometimes that vessel can dissect. There can be a small dissection that can happen, which is called leakage, or leakage or breakage in the cut in the wall of the aorta, and that can cause searing pain to the person, intense chest pain going to the back. And if the dissection is going up into the neck, the patient can have a stroke. If it's going in the hand, they can have a bunch of other symptoms. It can go down all the way to the abdomen. Sometimes people have isolated abdominal dissection. So this is a very, very severe and a very, very important and often a fatal condition, because either it's undiagnosed, delayed diagnosis, all these things, right? And the way to diagnose whether it's a stroke, pulmonary embolism, or aortic dissection is the radiological diagnosis, right? It's a CT scan, an MRI, maybe you need an echocardiogram, an X-ray. Now the person who's doing an X-ray know how to read the X-ray to look at for the one or two signs in for aortic dissection. So, the question is there any marker which is coming from the aorta that can help you predict that this person is having an aortic dissection, which can then become ubiquitous? Because these three conditions for which, whether it's a stroke, something in the brain, pulmonary embolism, something in the lung, or aortic dissection, something in the aorta, can significantly reduce mortality, right? Oftentimes we hear of people who are the young people dying of heart attacks. But we think they're dying of heart attacks, but they may be having any of these conditions, and we have not been able to adequately diagnose them, right? I mean, that's a very high possibility. So I think we are able to get some sort of lab quick diagnosis. I know it's not going to happen today. It's not going to happen tomorrow. But maybe we have to start thinking along those lines that maybe 10 years later, this can also be the standard of care, like troponins.
This is fantastic. Very apt for all the laboratories you are hearing this, and also for Roche, all manufacturers. I think a very, very good list. I'm going to move to Dr. Rajesh on the similar line that, while we give various biomarkers and various early diagnostic tests, technology advancement is extremely important. And you would have run some tests in the past which were not very sensitive, but you upgraded technology to make it much more sensitive and specific. Would you like to give some examples that how technology changed life for you reporting a result and also health clinician? Would you like to give some examples on that, please?
Sure. So, if I have to give some examples in terms of how the technology has helped us, the one test which comes to my mind, which is related to autoimmune disorders, is HLA-B27 test. Now, HLA-B27 test for a long time, and still most of the labs do use it, is flow cytometry as the methodology. But we all know that there is some limitation of this method, and there can be some cross reactivity leading to false positives with some another subtype of HLA, which is HLA-B5. Now, to make people understand what HLA and what I'm referring to, so HLA are certain antigens which we try and test on the WBCs from a blood sample which is collected, and the typical HLA haplotype that we try and identify by testing these HLA antigens on WBC have been known to be associated with certain autoimmune disorders. So one example which I'm quoting here is HLA-B27, which is very closely associated with ankylosing spondylitis. So HLA-B27 is often prescribed as one of the tests in the workup or in the diagnosis of ankylosing spondylitis. So for a long time, we have been using flow cytometry as a methodology for HLA-B27. But now with the advent of molecular tests and the kits being easily available, whether it is HLA-B27 PCR or whether it is HLA-B27 on a microarray. So both these methodologies, which are molecular-based tests, have changed the specificity for identifying HLA-B27. So that issue of false positivity because of cross reactivity with HLA-B5 and B7 also sometimes with HLA-B27 is completely ruled out with this technology which is molecular based. So this is one example which comes to my mind.
Excellent.
Another example which comes to my mind is some of which we already spoke earlier is Gene Expert. So Gene Expert, which has revolutionized the diagnosis for TB, not only in terms of the turnaround time, but also in terms of the specificity and some additional information. So not only that we are able to give specific diagnosis for TB in the shortest turnaround time, but with additional information on the drug resistance one. And the Gene Expert also evolved over a period of years where the sensitivity improved over a period of years, and the today's kit, which we talk about as Ultra, is one which goes as low as 10 CFU per ml as the sensitivity. And as Dr. Salil Vaniwala mentioned, with the XDR kit, if I use entire panel of antibiotic resistance is known. And in the shortest turnaround time, where with the TB culture, which still remains as the gold standard, but which is time consuming to as high as 21 days, versus here, the turnaround time is on the same day, the report comes on the same day, and our processing time is just about 3 to 4 hours, or even less than that. So these two comes to my mind as important revolutionary takeaways in terms of how technology has helped labs to offer better tests, better turnaround times, and with best of the sensitivities and specificities.
Excellent. I think these are very good examples. I want to go to Dr. Salil again on this. That on genomic space, what we should look forward to? What is the new recent advances which are going to come up in genomic space which will positively impact patient management?
Yeah. So, Dr. Nilesh, I want to answer the Dr. Samir's question that whether we have something in the lab which will give some information. Yes, there is something. There are lifestyle disorders related polymorphic markers. They are in the initial stages. For example, we are looking for ACT, angiotensin converting enzyme. That are just some other, there are markers which because of that you can say there is a increased risk of having high pressure. If there is something that you have a high increased risk of having a cardiac diseases. So there are different polymorphic markers coming into the field. They have not yet established or standardized, but according to the population and according to the number of tests which are being done, another 3 to 5 years time, we'll have all this information, early predictive marker to have this kind of a particular disease. So this is very important, and you have given a good chance to give this information. It is not standardized yet. A lot of labs are doing it, but the quality of the report, that is not because they are not doing properly, but because the availability of data is not good. That is the reason there is still a lot of limitations. But down the line, where more and more markers are available, more tests are being done, we'll be able to conclude that this is the marker which, if it is positive, that they have an increased risk of developing this kind of a cardiovascular disease or anything. Because we do it for our oncology patients. If you consider that there is a strong family history of CA breast, and we pick up those BRCA1 and 2 mutations, and we'll see it whether that's positive or not. But if it is a very strong history, we always prefer to do a comprehensive profiling of that, which is not only BRCA1 and 2, but there are a lot of other markers. That is an early diagnosis of having a breast cancer. We have so many patients who has a breast cancer. Sometimes you say that there is no family history. This is the first one who has developed a CA breast or an ovary, right? But that doesn't mean that patient is not going to have a BRCA positive, because this may be the first case in the family, and she will inherit this kind of a BRCA positive family. So we have multiple patients who have family history who are BRCA negative, but sometimes we found that they are ATM or some other genes which are positive for particular kind of a breast and ovarian cancer. So very importantly, you pick up early diagnosis. If you cannot treat that patient, at least you can save them. If you have a patient who has strong family history of adenomatous polyposis coli, so in that condition, it is very. Can you hear?
Yeah, we can hear you.
Yeah, so that is very important to pick up. You can do almost always colonoscopy or the other tests which are available in the stool to pick up early colon cancer. You can save that from the family. You can do pre-implantation, prenatal testing, doing a BRCA targeted and avoid that in the family members. So this is how there is another very important test coming up in the world that is known as early detection of cancer. There are 54 different cancer types which can be detected from the peripheral blood itself. That can be detected as early as 6 months prior to that particular cancer which is going to happen. So that is a very early detection, which is only one of the company in the US that has started doing it. And slowly it would be added by many more. So the important thing is early detection. You can pick up if there is a patient who shows early detection of CA pancreas, which is important. You cannot treat that patient because they are almost found in the advanced stages. If we can pick up, we have a therapy, you have targeted therapy, you can do whatever surgeries you want and take care of it. So early diagnosis is very important. Again, you can pick up minimal residual disease, which is coming up very fast. You can pick up the patient has been done a surgery 6 months or a year back using a specialized molecular testing from the liquid biopsies. You can pick up maybe 6 months or 7 months earlier than any other technology can be used. So this is the important. You can treat that patient. You have another therapies available. You can do whatever you want if you have this patient diagnosed in the early case or early in the first stages of the disease. So it is so broad. It is so important to take care all these tests. And these are all available right now in most of the labs in India, big labs in India, and they are very well done. You can rely on those, except the lifestyle disorders, which are still in the infancy for the polymorphic markers, which there is no information.
This was very useful, Dr. Salil. I'm going to move to Vijay, and in interest of time, I'm going to request to be shorter in answers henceforth. Vijay, what are the emerging trends? What is future trends in diagnostics, which I'm sure Roche would have done research and working on it? Can I have a quick glimpse on it?
Sure, Dr. Nilesh, thank you. We already have about 250 tests on serum work area, but nearly 50 assays are already in pipeline already. And these include oncology markers, these include dengue panel test, these include HCV duo antigen antibody, which we have recently launched. These include certain scores like case in example GAD score. This includes patient demographics, age, gender, as well as PIVCA and AFP test results into count to come up with the risk score. So definitely going forward, the focus is more on scores and combination of multiple markers tests. And for that, doing it manually is again a task. So we are working very heavily on AI-enabled IT solutions, specifically Navify. So Navify IT Solutions utilizes a repository of almost 800 clinical rules, which take into account demographics, age, gender, everything put together, along with multiple biomarker results to give you a certain indication that this patient would need this next. And this humanly will not be possible. So we need to employ artificial intelligence. We need to employ algorithms to make sure that all this comes together.
Right.
So that's in a nutshell.
Exciting, exciting. I'm going to move to case studies, but before that, I have one question common for both the doctors here, both the clinicians here. So I thought as before we started this session and we said we want to create a right picture of the lab. So far, we talked all positives about the lab that, we have so many tests, we do early diagnosis, we have a great technology, we keep innovating new marker. But is everything very, very rosy, if I have to say? And if I say everything is 100% sensitive, specific, accurate labs, the answer would be no. And hence, I want to stay very, very balanced on message to all our viewers that labs also have some limitations. Labs also can have some shortcoming and so on. And this, there is nobody better than both the doctors on the group to question on. I'm going to ask same common question for a quick answer from Dr. Samir to start with and Dr. Nandu afterwards. Are there any tests where you still keep facing challenges on quality of result? Maybe it is sensitivity, specificity, false positive, false negative, or variation in the result. Would you like to name some?
Yeah, so thank you so much, Dr. Shah. I think this is a very, very important point. And like I mentioned earlier, the tests help you either rule in or rule out a disease, right? That is, and then oftentimes it's also used to monitor the treatment, what you're giving. In my practice as a cardiologist, there are two tests which are often the bane of most doctors' existence. One is the PT-INR test, which is a test which is done for checking clotting. A lot of our patients are on blood thinners like acetylene. And acetylene makes your blood thin, and one of the ways to measure it is PT-INR. I have noted that PT-INR can vary on a day-to-day basis. I completely understand. I appreciate that. But once again, the test done in two separate labs at the same time, I've had this personal experience, have been considerably different. Similar things I have also noted in cholesterol reports. All things being considered equal, a person comes in, gets his cholesterol tested because checking cholesterol for a patient and he has to start cholesterol medicines. He is always fighting. He's like, why do I have to start it? Do I have to be on this medicine for life? So he always goes and gets a second checkup done, right? Before starting the medicine. And it's done fasting, but this time he chooses a different lab. And there is a 20-30% variation in the blood work in a span of 24 hours. The LDL values are differing, the triglyceride values are differing. I do understand some of it can be related to the lab, but this is a variation I see. Another important thing, HSCRP, right? This happened with somebody I know at a personal level. They checked his HSCRP. So CRP is a marker of inflammation. HSCRP is high sensitivity CRP, which it gives you a risk factor profile for cardiac diseases. So this person got his HSCRP, one of my cousins, he got his HSCRP tested, panel mein tha, he got it done. The CRP came back normal, the HSCRP came back borderline elevated. So very anxious, the person was like, yeah, my HSCRP is elevated. And then you start getting calls from everyone, the father, the mother, he's my son, he's working, should he start a cholesterol medicine, what should we do? So I talked, so over here I got the HSCRP repeated, I talked to my pathologist, she talked to somebody else, and the whole story short, so the way the HSCRP was being tested was different in one lab and different in the other lab, and that for some reason caused some variation in the reporting system, and that caused a lot of confusion. And then we subsequently got that HSCRP tested a few more times, and it was okay. So there are these small differences in the way these tests are done, the way the reports are interpreted, which really leaves us in a diagnostic dilemma, in a therapeutic dilemma. Is my medicine working? Should I start this person on a cholesterol medicine?
Stop here. I get message for 3 questions. I'm going to have a quick comment for Dr. Rajesh. Dr. Rajesh, you are giving message to all the viewers who are laboratorians. Would you like to give quick 3-4 advice on these 3 tests? Prothrombin time, what can go wrong? What care should be taken for ideal cholesterol value, right cholesterol value and CRP. Would you like to, we can do it jointly if required, but why don't you initiate this?
So when it comes to coagulation assays, the number one factor is pre-analytical. And there are a lot of things in terms of pre-analytical, right from the way the sample is collected, the way the sample is centrifuged. And this is all related to lab only. It's a part of lab process. But this is one very, very important variable which contributes to variation rather than the analytical part. So the issue is more into the pre-analytical part is what I'm trying to focus here. Number two, when it comes to coagulation and especially prothrombin time, yes, the analytical variation will be contributed across lab A and lab B if the methodologies are different. And that is something which always will remain and which a clinician should definitely actively look at what is the methodology used. Are we comparing apple to apple or are we comparing apple A to orange? So that is second point. And labs will mention what is the methodology. Second, in analytical and PT, if I have to address, good lab practices is also to mention the ISI value of the reagent used, because that gives a lot of better perspective when we are comparing the INR, which is a calculated parameter, across the two labs. If I have to compare the INR between the two labs, then the ISI also should be comparable. If many a times the labs do not give ISI value, we look at only the INR value and try and compare. And often always a lot of misinterpretation happens here. And this gets clarified when we discuss it out with the labs. So that is what I will add when it comes to coagulation part. When it comes to HSCRP, HSCRP and when you talk about HSCRP and CRP, actually it is the same molecule which you are measuring. It is only the sensitivity of the kit which is improved, and that is what is called as HSCRP. But the molecule remains the same as CRP. And yes, it is a marker of inflammation, as we have already said. And moment we say that it's a marker of inflammation, one should keep in mind that this is a marker which is the first one to rise, and the biology of this marker is where it comes down as it rises equally fast. So if we are talking about CRP readings being taken and compared which are more than 24 hours apart, yes, as an inherent biology of the marker, you will have something as a biological variation of that molecule itself inherently present, which should be included as a part of interpretation when we are looking at two particular labs. So biological variation is another very, very important point to be considered. And there are published guidelines and documents available now. There is something called as RECOS database now as latest as 2017, which is available, which is on website, which even clinician can refer to as lab person we refer to understand what is acceptable or allowable variance between the two tests, taking into consideration the biological variation parameter wise or test wise apart and overall apart from the analytical variation which a lab would have. And the third test was
Cholesterol.
yeah, cholesterol. So again on cholesterol, I would say that yes, cholesterol is quite a standardized parameter. Most of the biochemistry parameters today are standardized parameter, and we should not be seeing a large variation in cholesterol. When it comes to cholesterol and triglyceride is linked with food intake, but cholesterol is not so much dependent on food. So cholesterol should not show so much of variation as was discussed earlier. Definitely, we need to look at and discuss with both labs, and transparently, we should review and check if there was any kind of an analytical miss which has happened, and it should be equally transparently communicated to the clinician that this is what has happened or this is what was missed, and this is how we are going to correct it and ensure that it will not happen in future.
Great. Thank you so much, Dr. Rajesh. Nandu sir, instead of asking that question, I'm just coming up with one case study since we don't have a lot of time and which is quite relevant to kind of patient you see. So we talk lots about very sensitive tests, and I must indicate to you as a laboratorian that you become more sensitive, your specificity gets lost, and at times you'll end up giving false positive. And I want to give one case, and I have been advisor to few of the labs, and I want to tell you two of my labs whom I advise them, they are my customers, and they face this situation where a patient was reported HIV indeterminate, and both the patients sent a legal case, a legal notice to the lab. Now, how indeterminate was reported? that first time you did a test, which was HIV duo, which is antigen antibody both together, and value came borderline high, borderline positive. As per NACO guideline, they did it 3 times. So one lab got once positive and two alternate method gave negative, whereas other lab got two test positive and once third method gave negative. Any discordance as per NACO guidelines, you are supposed to report as indeterminate and advise the patient to repeat the test after a month. But as you understand, when a patient gets non-negative report, it's not positive, though interpreted borderline, patient cannot perceive it right. And hence patient, whenever he got test done from X lab, third party lab, he got negative and he felt this lab was wrong. I wanted to have your comments, whoever, Dr. Nandu specifically, any such case, what is your advice to labs? Would you treat the lab negative as wrong? What will be your comment for the lab? And as a laboratorian, I'm going to keep it open for Dr. Rajesh, Dr. Salil, any one of you to comment on. You are on mute, sir. You're on mute. You're on mute, sir.
Before I come to your answer, I would probably also like to make a mention about HbA1c. HbA1c is one thing which we say below 5.6 is the 5.6 or below is normal, above 6.5 is diabetic, in between is pre-diabetic or whatever. We see so many times patients who are either in the borderline range of HbA1c or HbA1c more than 6.5, and you see a fasting PP of plumb normal. Non-diabetic patients, young, no history of diabetes previously, not on any specific factors, which stress factors or anything, which are responsible for diabetes. Fasting PP plumb normal, maybe like 85 of fasting and PP of just 130 or something, or even less than that. Whether such patient you would look at doing the whole gamut of 24-hour checking or a non-invasive checking for continuous glucose monitoring, or whether you would really label them as diabetic, situations become very difficult in situations like that. I think this is one place where we probably are not really matching with really patient picking up a diabetic or non-diabetic. I don't know whether I would just depend only on HbA1c for confirming a diagnosis. Yeah, when I'm treating them, I know I'm going to put them below a particular level, but for diagnosis of HbA1c as diabetic, it becomes very difficult. Now, coming to the specific question about HIV, which you have mentioned. This is a long duration back, maybe about 25 years back, 23, 24 years back, I had a patient who was a medico who came with the same sort of a situation. He did as, during his period of Jainism, he took fasting and lost weight. Then he started eating everything, but he was still continuing to lose weight. So he became psychic. He thought that I am getting HIV positive. He did his testing done. And the testing was done by the Western dot. Straight away he went for it. And it was reported as borderline. Not borderline. They've done a different antigens, not typical, which you look at in patients with HIV, not typical GP120 or GP41 and those, but a different, even not even P24. It was like P25, some other P31 or some P34 or something, 33. And labeled as positive or question mark, very mark, indeterminate. He came to me. We asked him that maybe you could probably do a ELISA or something, and maybe if further comes up, then we could look up doing a quantitative or a qualitative viral RNA. He not only did his straight away went for his qualitative testing done, he also did his vibes report done also, and both came positive. Had titers around 8,000 or something. Did a quantitative test straight away. Then came back to me again with, oh, this is this. So I said, if that is the situation, just check up for the children, because if they are positive or not. He got his positive done, the children also came positive. And situation becomes such a panicky situation that a friend of his said, okay, let me do one thing, I'll help you around, let me come along with you, I'll do my testing also. So his testing report was given positive, his wife was given negative. 2 children also were given positive. So 7 people out of 8 were given positive report.
Oh.
All were negative, unfortunately. Oh. This patient, ELISAs were negative. So I was just wondering whether ELISA negative, positive PCR, whether he's got an early phase infection. But in such a situation, why could a child who is 9-year and 12-year-old could be positive? So clinical evaluation is equally important in patients like that, that you have to know that this is not possible. There is possibility of lab error. And if you don't rely on that particular issue, you have major problem. The amount of psychological trauma to that particular doctor for 3 months, he didn't go to work. Even
So
after he got a report which was negative.
my question,
So
that
this
if
is
I
what,
give you indeterminate report, is it appreciated by you or not appreciated by you?
I think, see, the aspect which are very clearly mentioned is when you have this sort of a report, either you'd probably do a Western blot or you can do a spouse's report.
It will come negative a Western blot in that case, because either it is very early, it's P24 antigen, Western blot is going to be antibody test, so it will come negative. Or second, it could be false positive. And we are
Right.
giving report indeterminate.
So this is one. Second thing is you could do in a situation like that, especially if this person is supposed to get married or something, they would probably look at qualitative RNA and see whether it is positive or negative. If it is high titers or something, you'd probably look at, oh, please try to see whether you really want to go ahead with it, or at least your spouse needs to know about it. So, because that can be picked up early, it can come positive very early phase.
A
Proviral
DNA can also be done. HIV proviral DNA.
Proviral DNA can be done, but proviral DNA again, not everybody does. Again, how early they are going to give the report. Well, qualitative RNA probably will be given much earlier.
Another thought is that suppose we hold a report, we don't report it, we do not release, we talk to clinician. I'm not getting similar answer by 3 different method, and answer is indeterminate. I would not like to release this report to patient. I would say, let's take blood after a month, do the test again and give the final answer instead of troubling and confusing the patient. How would you perceive that?
It should be perfectly fine in situations where there is no urgency of doing. See, HIV is never an urgency to really diagnose, except when you are really a serious patient has come with a serious illness, where it is different. Patient has just come for a routine checkup or he's not majorly ill and you are doing an HIV testing. It's never a very urgent reporting is required.
Only referring to those cases, and both these cases were similar. They had come for just pregnancy screening, prenatal checkup and so on, and that's what they got. Dr. Rajesh, any comment from you? And that would be the last. I think we need to wind up the session. We are already 5 minutes up, so we may have to wind up the session. Yeah, anything you want to comment on this subject?
So I think we do not have a full agreement on this. It's quite a debatable topic. But I would just say that the pre-test and post-test counseling, which is also a part of NACO guideline, plays a very, very important role here. That and if we have done that in a right spirit, I think these kind of complexities that we come across, then discussing it out with the patient as a part of that protocol, I think goes a long way. And I think that would and then the option as what you suggested, that we not give a report now but repeat it after a 1 month, also probably would be acceptable to the patient, because not having a report and waiting for 1 month, I mean just on a hypothetical as we are discussing, also would create some kind of an anxiety to the patient.
Yeah.
Which it has to be again again an acceptable option to the patient. And hence I said I don't think we can have a uniform one answer to this.
Yeah, thank you so
There
much.
will also be times where patient is doing just before his marriage, like 5 days before his marriage or a week before his marriage, and he gets this sort of report. He wants it early. So what do? You can't hold on probably in that situation.
So where you can hold, and I think majority of cases would not be in that framework. So probably you can hold it if possible. I'm going to little bit what notes I made, and I felt this will be very useful to the audience as well. As a laboratorian, sensitivity and specificity of the test is extremely important. That's one take-home message I want to give. Second thing, validating sensitivity specificity, using right technology and consistently upgrading the technology. There is no need to do, as Dr. Rajesh gave an example, HLA-B27 by flow cytometry solely, or maybe microlymphocytotoxicity, which is even older one, consistently when something like molecular tools are available. So upgrading on technology, upgrading on sensitive tests and checking them is very, very important for labs. Besides that, what Nandu sir gave a message very clearly is a panel standardization. If a doctor asks for one panel, thinking that all these ailments will be covered and your panel is short, it's a waste of time for patient and doctor, and patient management gets delayed. And this is one thing one should take care of it. We did talk about laboratories coming up with lots and lots of testing tool, and many tools are coming up. Vijay and Dr. Salil clearly mentioned about it. Okay, there are many more things are coming up. This is a journey which will continue, but are we still enough? I think both the clinician gave so many indications that we are still not done. The wish list is longer, and there's good sign for labs as well. Okay, I think we have lots to do, and that's very exciting. But while you do that, quality has to keep a pace. Both the clinicians have a lot of example to share where quality has not been optimally satisfactory to them, and that is one area our focus has to be optimum. Without quality, let's not start the test. And if you cannot manage quality, let's not run the lab. I would say, if you do a job, if you are making difference in patient life, let's make positive difference and not play with it. So quality is extremely important. It's a great message I get. And that's all from me. I think I have lots and lots of learning from this session. I want to thank all the panelists and NatHealth for organizing this seminar, spending all of you this time, and contributing for larger audience for all future to come. Thank you so much. Jaya, over to you.
Thank you so much. Thank you all of you for your invaluable insights and expertise today. Your contribution and insights have provided us with a deeper understanding of the crucial role diagnostics play in early disease detection and patient safety. So this session has been incredibly informative, highlighting the latest advancement, challenges, and opportunities in diagnostics. So we are truly grateful for your time and dedication. And together we can continue to drive improvements in healthcare and patient safety outcomes. Thank you.